Give me very great pleasure to introduce Dr. Grace Basal, who will introduce our guest speaker, Dr.
Hi, good morning. It's lovely to see such a nice audience, actually. And may I say that the comments from my colleagues who were here yesterday and who visited the Cavernoma Alliance station and also read through the literature is that your work has been very professionally set up and much admired by all the doctors and nurses that have visited. So a big clap to you, actually. Yeah. I must say that it's not often the viewpoint of doctors and nurses and clinicians when liaising with charities. So you've obviously been very well led. Yeah, really well led. Okay, so I've given this introduction to Ed Smith yesterday, but it was to a different audience altogether. And this is the touchy-feely introduction. I am a touchy-feely person as well as a doctor. So I just tell you the story how our collaboration with Ed Smith started. The neurofibromatosis nurse manager about 10 years ago persuaded me to go for the first time across the pond to the United States. I had never been, always just concentrating really on work and family. And I did it, and I went, and it was my first visit to the United States, and it was New Orleans, and it never stopped raining. And we think Manchester rains, but it never stopped raining. I've never had that experience. Actually, I stepped off the pavement once, and I fell because I miscalculated the depth of the road. There was so much water between the pavement and the road. Anyway, it was very warm, and we were constantly wet, but warm wet. The problem was that when you went into the lecture theatres, they were all fully air conditioning, so I spent 4 days in abject misery, soaking and freezing, listening to the worst lectures ever about research on mice. And you know, if you're a clinician, a practical clinician, mice really put you to sleep. Anyway, so when I was about to give up on life and slit my throat, the last session was about Moya Moya in NF1, and it was just like, oh my God, finally some sense. And I still remember that wonderful feeling of listening to one of the most outstanding lectures in my life. And at the end of it, I approached Ed and I told him that was wonderful. Could you please come to Manchester one day? And he said yes. And that was the start of a real wonderful collaboration. Ed has never charged us for his visits here. He spent 2 or 3 days with us. He gives lectures ad nauseam. He gave one yesterday, one today. He stays with me at my home, bless him. And he has been beyond generous with us. We are incredibly grateful. You are in for a treat. You will enjoy his speech. You will enjoy his lecture. You will enjoy his interaction. But I would encourage you to also appreciate the humanity behind the professor. Thank you.
I don't know who that introduction was about, but I'd love to meet that guy. I want to thank everybody for the very kind invitation coming out here. It's a real honor and a real pleasure, actually, to speak to the folks here. I would like to applaud as well the incredible work you've been doing. I've now been fortunate enough to come for a couple of years, and it's truly impressive what this organization has done. And so I really want to echo the comments of how amazing it is to see what's being done here. I was asked to talk a little bit today about advances in cavernoma treatment, and I realize I only have 4 hours to speak, so I'll try to move it along quickly and make sure we're done on time. So, you know, in trying to think about what to speak about, I think some of the questions that I've heard, at least in my practice back home, are fairly routine, and I looked at your handbook today. They seem to be some of the same ones, which are, you know, what are they, why are they a problem, some of the treatment issues, you know, what is the natural history, what's really happening, and as a surgeon, the questions I get a lot are, you know, how do we pick people for surgery? When do we not do surgery? And I think these questions are common because they're not very well answered, and I'm going to try to tackle a little bit of some of these today as best I can. I think the other big thing are, you know, it's very easy, I think, to become complacent and just accepting of, well, this is the way things are. And I think one of our jobs and one of our missions, and especially for organizations like this that are so energized and so devoted, are to challenge ourselves to innovate, to try to do new things so that we're not just sitting on our heels and we're actually trying to push the field forward. And some of those questions are, you know, who should we be treating? If we're surgeons like myself, or you've had family members or yourselves that have gone through surgery, how can we make surgery better? And importantly, one of my big goals is to put myself out of business. Are there novel treatments, are there things other than surgery we can do to treat cavernomas that will make my job obsolete? Because I could do with a little time off, I gotta be honest. I don't need to tell the audience here, you know, what cavernomas are. These are sort of endothelial-lined blebs of low-flow blood vessels. They've been described in the U.S. as looking a little bit like mulberries. I've actually never seen a mulberry, but I've seen a lot of cavernous malformations. So I would say a mulberry looks like a cavernous malformation. And as you know, there's a number of genes that have been described in association with these. They're problems, obviously, because they can do bad things to the nervous system. They can grow, they can bleed, they can swell. This is a little spot in the spinal cord that was missed in a young child, and then a little while later had a bleed, very tiny, something the size of a pea, and led this poor child to have a very difficult and bad outcome, which fortunately has gotten better, but nonetheless, you know, these things can cause serious problems based on their location. So we know what these are, we know generally why they're problems, and the real question, I think, and why these groups, you know, like you folks exist, is to say, well, what are we going to do about them, right? And now that they exist, how do we tackle them? How do we make things better? And one of the things we've tried to do in the US, and obviously you're doing here, is to build a team. Now, I don't want to pick sides here in Manchester. I'm trying to be very neutral. We're an inflammatory president. I'm just here as a medical emissary. So we're just trying to build a team. And one of the things which I think is very inspiring from what I see here with the, you know, the Cavernoma group and what we've tried to do in the hospital is understand that it can't be just a group of surgeons or a group of neuropsychologists or a group of patients or a group of scientists. We need to bring all of these folks together. You're doing it here with this group. What we've done in our hospital is to create it's the worst acronym ever. It's the Cerebral Vascular Surgery and Intervention Center. The acronym is pronounced CSIC, which really is self-marketing a lot. But we have tried to bring together for the first time, at least at our institution in the US, all these disparate groups, so you have one-stop shopping both for the patients when they come in and get seen, but also for moving the field forward so we can feed off each other and cross-pollinate. We have team-based care. So traditionally in the US at least, it's organ-based care. You have the orthopedics team for bones, you have the neurosurgery team for brains, you have the cardiology team for hearts. And that's not the problem with cavernomas, for example. It can affect the nervous system, it can affect neuropsychology, it can affect neurology. There's many different things. We try to bring them all in one team. It's easier for patients and it's easier for physicians to work together. It's really been a paradigm shift for how we treat these kids. For research, we bring the researchers into our clinical meetings. These scientists come and sit with our weekly rounds because we want to understand how we can push the field forward, not just have them in two separate towers, one swizzling test tubes and the other seeing patients. And the last thing is, I think one of our important goals, and what I'm hearing here is, just like with the Cavernoma Alliance here trying to promote the future, we are actively trying to bring people into the field of cerebral vascular disease and cavernomas because we want to train the next generation of surgeon scientists, people that are able to push the field forward and not just be rote clinicians or not just be rote scientists. And so building a team, I think, is incredibly important, and I laud what you're doing here. Part of the offshoot of that, and this is one of these great collaborations where I get to meet people like Grace or Ian or the other folks here, is that we can perform these clinical studies together. One of the big problems, even though this is, you know, a major life event for all of the folks here in this room, in general, cavernomas are somewhat rare, as are many other cerebral vascular diseases. And so there's a lot of limited history. A lot of the questions we're asking is we don't have a lot of these around. And one of the most important things are putting together evidence-based plans, learning with collective groups. We've got the new American Heart Association guidelines coming out this year, and it's great because for the first time they're informed in part by what patients have been able to contribute through groups like this, the Angioma Alliance in the US, and what you folks have here. And so this is really influencing how we're taking care of patients because of groups like this. And I really think it also focuses these type of patient advocacy groups inform us as clinicians and scientists about what we need to learn. We may think something's important, but what we need is folks who are involved and affected by the disease to say, look, Ed, you know what? This is what's really a problem. Put your test tubes to work on this. And I think this is an amazingly important part of how this field is evolving and what we need to do. Along those questions are, who do we treat, right? So in order to figure out who to treat, one of the most important things is to understand which cavernomas are problems and which cavernomas kind of sit there quietly and don't do much. So we did a big natural history study which came out a couple of years ago, and we looked at presentations, and one thing we found is that about a quarter of the cavernomas are found incidentally, about a third present with seizures, and about 2/3 present with hemorrhage, either with or without a seizure. That's why they overlap in terms of numbers. And as you might imagine, the vast majority of them are supratentorial, meaning up in the top part of the brain, and then the rest of them are laid out sort of in the amount of substance that exists within the brain. We see new cavernomas relatively rarely sprouting up, particularly in the incidental form. So if it's a single cavernoma, really the likelihood of getting something new is very, very low likelihood, less than 1% per year. So it's something where you really have a better sense of answering some of these questions for families if they're coming in out of the blue. Now, another big question we get a lot is, what makes them bleed, right? I mean, hey doc, I've got this thing, is there stuff that's gonna make me more prone to bleeding? And so there's a very nice study, this isn't our work, this is by some colleagues out in California, but they did a very nice, elegant study looking at vascular malformations and taking all the records of what brought people into the hospital before bleeds. And what they've been able to show is that, luckily, with most routine types of things, including trauma, these are probably not triggers for hemorrhage. So while I wouldn't advise you to go out and get hit in the head, the odds are that it's not going to be very likely for increasing the likelihood of bleeding. Similarly, infection, again, there's always the anecdotal story of the individual person that's had an event, but from a big population-based study with 2.3 million folks, we can show that that's probably pretty unlikely. And again, with blood thinning agents, while high-dose blood thinning is probably increasing the risk, routine things like a baby aspirin probably do not increase the risk very much. So this I think, is a very nice study with a practical answer for some of the stuff that allows people to be physically active and be a little less worried, we hope, in terms of getting out and being active, as you heard in the previous talk. In terms of how often they bleed, it's pretty darn low. Again, if it's incidentally found, the risk of bleeding is 0.5% or so per year in a big population-based study. So again, while there's always the anecdotal story, I think these bigger numbers help to reassure us a little bit. The thing that is difficult is once there is a bleed, it seems that makes these cavernomas a little more irritated, if you will, and the rebleeding rate, especially in the first 3 years, is pretty high. So we know that once these little bubbles have popped, they tend to be a little more dangerous and irritated, and during that short window, this is when you have to be a little more diligent about following things. We looked at this over a long period of time, and what we found is that really the rebleed rate is highest in the first 5 years, really in the first 3 years. And I think this is super helpful because it informs how often folks maybe should get scans or be seen by their physicians. And I think this helps us to maybe relax a little bit as you get further out from a bleed and know when you should be worried and when you can relax. And I think this again speaks to the previous talk about managing your anxiety a little bit. Having this information, I think, helps us to understand a little bit when we should be nervous and when we can relax. Now, with that idea of bleeding in general, what about specific locations? Are there certain parts of the brain or the nervous system that we need to be a little more concerned about? One of the areas we hear about a lot is the basal ganglia, this part deep inside the brain that controls movement or starting of movement. And these are relatively rare, but the good thing about these is that you'll see that although there are a fair number of them that have been found, generally only the bigger ones are the troublemakers. And if they're small, a couple of centimeters or less, they seem to be less concerning. So, speaking as American, we like to take home messages, keep it short, keep it bullet points. In the patients that have cavernomas in this tricky part called the basal ganglia, if it's big or it's causing symptoms, so more than 2 centimeters and it's bleeding, you should take it out. On the other hand, if it's small or it's not bleeding, our study would suggest that you can probably get by pretty well with leaving this alone. So again, this is a nice piece of information. One of the most common places elsewhere is what's called supratentorial lobar cavernous malformation. Sound fancy at the pub if you say that, but you know, the normal ones that are up here is probably the regular way of saying it. And these are by far the most common. And because they're in a part of the brain that tends to be a trigger for seizures, and we've heard a lot about that already today, one of the questions we hear is, will this treatment of this cavernoma with surgery help manage seizure? And what we can see here is that when you remove these cavernous malformations with surgery, you really do help improve seizures in 96% of patients. So while you don't necessarily have to operate on them if the seizures are well controlled, if the seizures are not well controlled and surgery is recommended, the good news is that surgery works pretty darn well. The other thing here is that when you remove these, what you can find is that for all comers, not just our study, but all the studies in the past couple of decades looking at cavernomas, looking specifically at kids, but also with adults, you have a very high 94% rate of an Engel 1, meaning a really good control of seizures. So I think what this suggests is that for those folks who are afflicted with seizures that can't be controlled well with medications, and that it is generally the first line of therapy, if you can't control them and you have them in this upper part of the brain, the good news is that surgery is a pretty darn good long-term treatment for this. And again, bullet point here, speaking sort of as the loudmouth American, the thought is surgery, if you need it, just do it, because it seems to have an effective treatment. Now, as good as these treatments are, as good as having these understandings are, you know, we always want to ask, how can we do better? How can we make things better than they are now? We can't just follow the trodden path. We need to push the field and advance what we're doing. And so, speaking as a surgeon, I want to start off with some ideas of how we can make surgery better, right? So, with surgery advances, it's kind of like driving here in London, in Manchester. You got to look both ways. You want to get where you're going safely. So we've tried a number of different advances. I'm going to walk through what some of these are that we're using in the US. One of them is, you know, a lot of people have talked about brainstem cavernomas, and these are particularly troublesome because they can be difficult to reach. And one of the most simple advances we've tried to work on is using different tools to get to these difficult lesions more safely. And we describe this approach where we can come in sort of underneath the bottom part of the brain and get to these midbrain lesions a little bit more safely through a new corridor. And again, some yucky surgery pictures here, but what we've found is that there are certain parts of the brainstem that are more forgiving for us as surgeons to enter through and take out these bad cavernomas that are bleeding or rebleeding. And so from a very simplistic standpoint, this is one avenue by which, as surgeons, we can get where we need to go to potentially treat these troublesome brainstem cavernomas more effectively. Now, as nice as that is, that's not really a big innovation. That's more just mapping out a different way to do the same technique. One thing that I'd like to be as a surgeon, or especially if I were a patient, is to be less invasive, right? What about making surgery smaller? What about making it quicker? What about making something that doesn't hurt as much? And so, again, this is an idea, I think, where we had a very smart group of residents, you know, or registrars, I guess you call them here, mixing high-tech and simple, making a very tiny opening in the skull, and then using ultrasound to real time during the surgery have immediate guidance where we're going. People have used, you know, this navigation. People may have heard about this, where you have this like GPS machine. But the problem is with cavernomas, sometimes they bleed, sometimes the brain shifts a little bit in between when the MRI is taken and when you do the surgery, or even during the surgery as you open up your incision, a little bit of air gets in and things kind of move around, and sometimes it can be hard to see where you need to go because things shift. The nice thing about ultrasound is it's immediate real-time imaging, and what we do is we pass a little catheter right to where the lesion is, so if they're deep inside the brain, if they're hard to get to, and it lets us track a very immediate course very quickly, which saves time. And again, a few yucky surgery pictures here, but essentially within about 2 or 3 minutes, we can take an ultrasound here, pass this catheter in, we can see exactly where we're going directly to the cavernoma, and we have a very tiny opening to let us get immediately to the surgery. we can follow this right down the catheter, which takes us right to where our bad spot is, and you can see we make a very small linear opening right to where we need to go. So the advantage of this is a very quick, very short way of getting where we want to go, mixing high tech and old school to make our surgeries faster, safer, and better. One of the things we're working with in the US to try to make surgery even less invasive is the use of lasers, or as they say in the movies, lasers. But you know, this is something where increasingly the thought is that with cavernomas, it may be possible to use these very tiny optic lasers where you simply make a little opening the size of a pence, I don't know what the right word is over here, a dime in the US, but just less than a centimeter or so, and you can thread this tiny wire in, and then just with a laser essentially ablate the cavernoma. This is a little bit experimental. This is something that certainly is not common practice, at least in the US as yet, but I think it's got a great deal of promise. And the advantage here is it's something where previously you do a craniotomy and you do an operation, take something out that might involve 5 or 6 days in the hospital. You're able to do this now in the span of an hour or so, and you can usually go home the next day. So the hope here is that we're moving our ways more and more to less invasive surgeries to treat these. Now, with all these here, one of the big things as surgeons as well is, you know, we've made these advances, we're trying to push the field forward, but how can we apply these surgical advances? One other thing that's really important is to make sure we're as effective and as good as we can be when we get to the operating room. And one big push we've had in the US and especially at Boston Children's is this idea of 3D printing. So what we've done is we've been able to print individual lesions. You get a cavernoma sent to us from wherever. We had a patient from China a few months ago, and they emailed us their MRI images as they were getting on the plane, and by the time they landed in Boston, we had printed up a specific model of their cavernoma. And so we can do the surgery before we actually do the surgery. We have a great facility here where we have 2 different simulation centers on the Harvard campus, literally right across the street from the operating room, and we can take films. We have a group of folks that can print these, and then we are able to create these models that allow us to see it in a way that simply isn't the same as looking at it with the 3D goggles, or you know, actually as a surgeon you hold it in your hand, and importantly you can rehearse and practice the surgery just like airline pilots use flight simulators. It increases that level of safety. The way this happens is we put in a request here. They make computer models to show us, you know, do we want to see it transparent? Do we want to see it with regular brain tissue? Do we want it bigger? Do we want it smaller? And this is an example of a cavernoma here I operated on a couple weeks ago. You can see the brain here in transparent image. They can also make a skeleton image and shows where the cavernoma is right next to these important blood vessels. So I have a sense of what this looks like. The way we do this is they actually print this for us, so we can make different resins in there. We can have hard stuff for bone with one plastic, softer stuff for brain tissue, and that we can actually simulate with a drill, with your scalpel, exactly what you're doing. And this is a little example of how it's actually used. So this is with a different type of vascular lesion that we recently published. But essentially, this is what it looks like on images. You can kind of get a sense of it, but then you can print it in 3D models. And here's the lesion right here. We can make it twice normal size. We can make it life size. We can make it with a transparent thing, so you have like Superman X-ray vision. You can see it many different ways. And then during the surgery, you're deep inside the brain, but you're able to see how this matches exactly where this blood vessel is and where the lesion is. So you can avoid the dangerous blood vessels, but get to where the problem is very safely. And you have that real-time reference during the procedure. You've rehearsed it beforehand, you've done the surgery beforehand, and then when you get to the operating room, you feel like this is deja vu. You've done this already. You can move more efficiently, you can move more quickly, you can take these out, ideally, without the same problem. So we've done this, we've published this, we've looked at a number of vascular lesions, and what we've shown, first of all, the models are really good. Whoever these nerds are that are making these computers, they're pretty good at what they do. There's 98% concordance between the model and the operative field. So they've matched this very well. We've taken real-time operative photos and compared them to the actual machine. There's less than 2 millimeter variation between the plastic model and the actual tissue at the time of surgery. And most importantly, we've shown with multiple vascular cases now, including cavernomas, a 12% reduction of OR time. This doesn't only make the administrators happy because it's cheaper with more ORA time, it's better for the patient because they're under anesthesia for less time, the surgery is safer, you're able to get the job done quicker and get the patient off the table and quicker to recovery with less time fiddling around and wondering what you're doing. So I think this has been a really nice advance that has practically married some high-tech nerd stuff with some real-time patient advances. Now, these are technical advances, these are all surgery. And they're neat and they're nifty and they help patients. But I think one of my jobs as a scientist, I hope, is to think beyond just what a surgeon does, but say, what else can we do beyond technical advances in the OR? How can we advance the care of patients with cavernous malformations beyond just a sharper knife or a brighter microscope? And this is where they keep me inside the box back home. It's nice to be outside with my ankle bracelet on. So there's been a lot of new ideas. You've probably heard of many of these from either your group here or from the US or other places around the world. A number of drug therapies have been talked about for cavernomas, Rho kinase inhibitors, inflammation modulators, beta blockers, thrombospondin is an angiogenesis modulator. People have talked about diet just in the past year, this idea of microbiome and sort of modulating what you eat to somehow affect the bleeding rates of the cavernomas, vitamin D3. So these are all existing trials, and some of them I think have great promise, some of them I think are a little fringy, but nonetheless they all are advancing the field and are great. I think one of the questions is, for myself personally, what should we study? And I want to end here by talking a little bit about some of the ways that I'm trying to study the underlying biology of these cavernous malformations in order to try to advance the treatment of them in novel ways that don't just involve a sharper scalpel or a brighter microscope. So I talked yesterday a little bit about this. This has been something that's been really big in my lab. These proteins called axonal guidance factors. So these are proteins that are involved in building a brain. Before you're born, these proteins exist and they build brains and blood vessels. And then they're supposed to be turned off after birth. They're supposed to vanish. They're like a sleeper program. And we have found that this process of growing blood vessels and growing brains are the exact same things that are good in babies are bad in adults. They seem to form brain tumors. They seem to form blood vessel malformations like cavernous malformations. We've published a number of papers showing that these particular proteins, like sleeper agents, can be turned back on in disease states to essentially work nefarious purposes later in life, like with cavernous malformations or AVMs. They're bad in tumor because these things tend to promote invasion and tumor growth. And one of the questions is, if we can manipulate them the right way, could they be good in vascular disease? Can we take the abnormal processes going on, for example, in cavernomas, utilize these so-called sleeper programs and axonal guidance factors and have them make these endothelial cells become healthy again that have been affected by the mutation so that the cavernomas are less likely to bleed and more likely to behave themselves? So we've looked at a specific protein called netrin-1. This is sort of the main driver of blood vessel growth and sprouting. And one of our thoughts is this may be abnormally regulated in blood vessel malformations like cavernomas. And so we decided to look at how they control invasion and migration. So looking at this with netrin, we took a bunch of blood vessel cells, endothelial cells, just like that are in cavernomas, and we put them in this little well here. And the idea is that if you are exposing them to certain proteins, they behave in certain ways. So, for example, there's a protein called VEGF, and that's like the reigning champ. This is the protein that makes blood vessel cells migrate and invade. And so we took the reigning champ and we put it up against our proposed new challenger, netrin. And what you can see with this fancy graph here is that netrin makes these blood vessel cells invade and migrate to a greater extent for a longer period of time than does VEGF, the reigning champ. So we're on to something here about controlling biology. We then looked and said, well, how does it do this? And one thing we looked at is we said, okay, inside the cells are these little engines called kinases. And they're the machines inside the cell, like the engine inside your car, that drive these cells to migrate and move around. And what we show is that there's a particular time when the engine is turned on. It's called the phosphorylation of the kinase. Again, if you want to impress people at the pub tonight, you can throw that out. But simply what it means is this little black bar, when it shows up on this gel, the more that's here, the stronger the engine is running. And again, comparing the reigning champ of VEGF to the new challenger of Netrin, you can see that Netrin turns this engine on for a longer and stronger period of time inside the cells, driving these cells to behave differently than they should otherwise. And the last thing we did is we took these cells and we put them in a petri dish. And what we showed is that when you add Netrin, when you sprinkle this sort of bad guy protein on, they create a lot more behaved tubes. They form together and they behave and they build normal tubes and they sprout appropriately. Whereas when you block them, what you find is that the tubes fall apart. So wouldn't it be neat to hypothesize that you could take cavernomas, for example, where they don't stick together very well, the blood vessel cells, and perhaps treat them with a variant of this to make them stick together better and maybe not bleed or not bleed as much. This would be a biologically driven therapy that might put us surgeons out of business. So thinking, how can we use this? And of course, the first thing I thought about when talking about how to use this was, how about a urine test? Because as a neurosurgeon, that's really what I think of all the time. People have had coffee now, right? They're ready to talk about a urine test. There's a picture of Dr. Kamali right here as a young man. So people say to me, hey, wait a minute, we were just all, brain the last 20 minutes, and all of a sudden, boom, you talk about urine, what's going on? Well, a focus of my lab for a long time has been urinary biomarkers, looking at proteins in the urine to try to understand what's going on in the brain. And so you say, why do you do this? Well, it's non-invasive. There's no need to sedate people. It's very cheap. It's 10 to 100 times cheaper than MRIs. It's easy. There's no needles or pointy things. And you can ship them. It puts the P in UPS. The P. That's why they're yellow and brown on the vans. And we have a trial where we're doing this. And they're sensitive and specific. So you actually get a numerical value as opposed to holding up a scan and looking at stuff. So it makes really good sense from a very practical standpoint to say, could we monitor this disease in a non-invasive way, very cheaply, not to get rid of MRIs, but maybe to help reduce the need for MRIs, or to make MRIs more sensitive to say, well, who's at risk of bleeding? Who's at risk of not bleeding? How can we follow this along? And so we did a study with this where we took a whole bunch of patients with vascular lesions, including cavernous malformations. We collected their urine bank, and boy, do my techs love taking care of that part of the lab. And then we looked at the levels of various proteins and compared them to healthy folks afterwards. And what we saw is in looking at cavernomas and other vascular malformations, by looking at the levels of the proteins in the urine of patients with vascular malformations like cavernomas and comparing them to age and sex match controls, we could determine who had cavernomas with about a 91% sensitivity and 87% specificity, similar to a pregnancy test. So it's not perfect, but it's a proof of principle that suggests that we could perhaps use this tool in a very practical way down the road. And that asks the question then, do you have any examples of how you could actually use this, right? Let's take this from the laboratory and how can you actually bring it to the clinics? So I want to show an example of how I've done this already with tumor and how I think it could potentially be used with cavernomas. So this is a young man I treated a long time ago. He had a big brain tumor here, and before surgery, we had him pee in a cup and we measured how much of this protein was around. And we saw that when the tumor is present, there was a lot of protein present. And so then, after that, we take the tumor out. He does very well. 6 weeks later, we check his urine, and sure as shooting, the urine levels have vanished. So tumor present, levels present, tumor gone, levels gone. And I'm going, great, this is awesome science, I'm happy, I'm going to book a flight to get my Nobel Prize, everything's amazing. And then the radiologists call me, they say, Ed, bad news, the tumor's come back. They go, oh, the poor kid, and we check his urine beforehand, and there's really no level of the protein. And so I said, well, I didn't really say rats, but it's a mixed company here, so I won't say what I really said, but it was like rats, but more inappropriate, because I had thought that had the tumor come back, what I should have seen is this level should have come back, and it didn't. So I brought the kid to the operating room. I was ejected both for the kid and for my science, but as soon as we took it out, pathology showed there was no tumor. That in fact the urine test was correct, and had we waited, we could have avoided this child getting another surgery. This was just scar tissue, and wouldn't this be amazing if we were able to save this child an operation because of a urine test? And I think for cavernomas, you could propose that you could do a similar sort of thing. What could we do with this work? There's a lot that could be done. And again, I want to show you what we've done with some other diseases where I think we could go with this with cavernoma. So We just published this about a year ago. If you look, netrin as a single protein is interesting, but I think the real elegance here is to understand that different diseases have different fingerprints. So I know it sounds weird to talk about fingerprints in the urine. I don't know what people are doing back there in the restrooms, but the idea is that you could essentially, we published, for example, with 2 different types of brain tumors. You can pee in a cup and not just figure out whether or not you have a brain tumor, but what kind of brain tumor you have, just based on the urinary protein profile with 98% accuracy. And this has been looked at not just for tumors, but we looked at cavernomas, we looked at moya, we looked at AVMs, and the thing is that each different disease seems to have a unique biomarker signature that we can detect in the urine. It would be wonderful to be able to look at this potentially and help us down the road. When we resect them and we take them out, we can show that with tumors, the amount of tumor we take out matches with the corresponding decrease with the biomarker levels. So you have a measure that you can sort of get a sense of the disease burden just by looking in the pee. So how can we use this in vascular disease? Well, ideally, I would love to be able to say that using these urinary, non-invasive, cheap tests you can do from home instead of driving to the hospital for an MRI, you might have a better sense of, do you have a cavernoma? Is the cavernoma bled? If you've taken the cavernoma out, is it still gone or has it come back? Is it time to go for a scan or not? These are all questions that might be able to be answered that we're now answering in tumor that I think we might be able to use in cavernoma. This is important because this idea of using these biomarkers could help us with the diagnosis and the discovery of disease. It could help us with follow-up. Has the therapy been effective, and how is it working? And maybe with prognosis, which of these are more likely to bleed and which aren't. Equally important, separate from just diagnosis and prognosis, not just getting a better crystal ball, but we could actually use this as a therapeutic target. We might be able to change the ability of these endothelial cells to stick to one another and hopefully reduce the risk of bleeding down the road and use this as a chemical therapy to maybe change the course of disease in some of these patients. We've just completed a multi-center trial for brain tumors looking at this, and I would love to be able to do this in cavernomas as well, where these types of groups, these patient groups where they come together to advocate for change, this is how we can enroll people and do these kind of studies. So I want to wrap up here on time. There's a little picture of the Boston Pea Party right here, a little history and science mixed together, very nice. So to wrap up, I think, cavernous malformations obviously are a very significant healthcare burden for affected patients and families. And I think improving outcomes for children and adults will require advances from multiple disciplines. We can't do this in silos. We need to work together with multiple different groups, with families, with all the different folks that have a stake in the game. And I think we should be able to stratify risk through big population studies by pooling the experience of many different places here in the UK, in the US, and France, all around the world. And that will help us, along with things like biomarker development, to clarify the best treatment plan for each individual so we can give a smarter and safer idea of treatment. I think kids and adults with cavernous malformations, I hope, will benefit from these novel advances pushing the field forward, whether it's operative techniques, advances in molecular biology, 3D printing, simulation, most importantly, all of us working together to advance these fields. So it's been a real pleasure to be able to share some of this research and some of these advances with you. I want to applaud again the fact that this is happening because you folks are making it happen through your contributions, your work, your tireless efforts for the research, and I really want to applaud the work that you're doing, and thank you for your attention to hearing a little bit about mine. Thanks.
Thank you very much, Dr. Dave. I'm like Dr. Basal, I'm a fan. Well, thank you very much indeed. Any questions for Dr. Smith?
Thank you. Thank you for a most enjoyable talk, particularly on those biomarkers and that potential. Can I ask you a question on, you originally mentioned limited data.
Yes.
And rebleeds are important for us all. It's one of the key issues that we're concerned with. And in 2002, I was looking at brainstem rebleeds, and the data, the population, was staggeringly low.
Right.
So, it was 40, 60, 80, and I'm sure not statistically significant. Has it got a lot better?
It hasn't, and I think, when you look at some of our population-based studies, 6 or 7%, I forget the exact number, are brainstem cavernomas to begin with.
Yeah.
So you've got a relatively limited disease. Of that, a very tiny percentage are actually in the brainstem, and of that, a very tiny amount actually go on to bleed. So you're dealing with very, very tiny numbers. I think there's two solutions to that. One solution is exactly what's happening today, which is pooling multiple centers. One of the big problems, as you've seen from the research, is this is the University of XYZ, and here's my 6 patients, and here's the University of ABC, and here's my 7 patients. And I think a group study with well-controlled populations is one way to answer this. And that's where these kind of groups can advocate for that. The second is, I think, understanding the biology of why they bleed, looking at them and saying, well, these are the triggers that are the incipient warning signs of hemorrhage, whether it's through fancy MRI imaging, and Stavros, some of the radiology folks may talk about this, whether it's biomarkers. I think independent from large group studies, a separate avenue might be to look at the biology of why they bleed. But the short answer is we have not made great advances in that, and I think this is exactly why pushing these forward is so important.
Thank you.
How far off urine testing are we in the UK?
I have no idea how things are in the UK, so I'm afraid I can't answer that very well. I would love to be able to, work on groups and studies here and pooling folks. I think it would be, pooling is probably not the right word, but I mean, it's something where getting these trials going involve a lot of time and effort. You really have to make sure you do them carefully and appropriately. But I would love to, one of the advantages of these type of meetings is to try to spark plug those type of ideas.
Please come to the Caver families. You can have all our children.
Can I ask a multifaceted question?
I'll do my best to answer. I get very nervous, as you can tell. I'm shy.
I can tell that. Well, I'm nervous too. Myself and another parent were talking about calcification, and I wonder if you can explain what calcification is.
Sure. So the question is, what is calcification? And in the simplest term, that is when the body has some sort of injury or insult, the response is that the cells that come to kind of clean up the problem that's there sometimes will deposit or leave behind a little bit of calcium, the same stuff that makes up your bones. In and of itself, calcium is not a bad problem. It's part of your natural body. It doesn't do anything terribly bad, but it is an important finding for two reasons. One, it tells you something has gone on, at least in the past. It's kind of like seeing rust on a pipe. Maybe there's not a leak now, maybe there is, but there was at some point in the past. And the second thing is it helps you understand sometimes what sort of disease you're looking at. Obviously, if you know the cavernomas are there, then it's a little less of a diagnostic problem. But if you're looking as a neurosurgeon or a neurologist and you have something new, certain types of conditions will have calcium and other ones won't. So it's an important diagnostic tool. In and of itself, not necessarily anything too terrible though.
But could calcification cause other neurological problems outside the problems caused by the cavernomas?
So the question is, could calcification cause other problems outside of the cavernoma? I would maybe defer to some of the other neurology folks here if they'd like to chime in, but as a limited neurosurgeon, I would say no. I think the problem really is the cavernoma itself, whether it bleeds, whether it expands, but I don't think the calcium in and of itself, at least in my experience, is any problem.
Okay, well, given that answer, I'll shut up. Thank you.
No problem.
Hello, I was wondering if you could expand further in the ultrasound method, surgery method, how long has been in practice and the percentage of success without leaving problems afterwards?
So the question is the ultrasound method, how long has it been around and how successful is it?
Exactly.
So variations of it have been around for a very long time, as long as ultrasound has been around in the operating room. As I mentioned in the talk, this isn't really some groundbreaking Nobel Prize winning move. The idea is simply two things that are done differently. One is you're using real-time imaging, so you're accounting for movement of the brain during the surgery, and I think that helps make things safer. The second is that it really helps, I think, the speed of the operation. And in our paper for that, we're able to, it's similar to the 3D model, we're able to cut down about 10% of the time of the operating time. It's not a huge change, but the point is every time in the operating room that you have a few fewer minutes, the better it is for the patient. It works incredibly well. You don't want to use it on certain types of vascular lesions because if you poke something bleedy with a sharp thing, that's not good. But cavernous malformations, tumors are very well suited for this. I wouldn't use this for an aneurysm or an AVM or something like that.
So there's 3 quick questions from the Facebook group. The first is, are there any large multinational research studies into cavernoma at present?
To my knowledge, no, but I may not be as well informed as others, so I will say that as a limited neurosurgeon, pediatric neurosurgeon, not to my knowledge, but I could be wrong. My wife tells me I'm wrong a lot.
Okay, the next one is, could you provide scientific references for your work for the people at home to read?
Yes, I can. I'll send a little email after, and I will be able to put those out. And if people want to put themselves to sleep, it's better than a good stiff shot of port in the night.
And then quickly the last one, has 3D printing pre-op been used, or is it available in the UK or EU hospitals?
I think they do at a number of hospitals. I'm not positive. At Manchester, Ian, do you folks have it here?
We haven't done 3D printing, but you were talking about the navigation systems, so
right.
You can sort of do a virtual tour of the lesion rather than having a physical thing. You can move the head around and look using the navigation systems that we have there, and that's what I tend to do for the operations that I have.
Yeah.
Can I pass a comment about that? So I've heard that Media City, hello? That Media City have done some 3D printing for a massive neurofibroma involving the airway, and so the anaesthetist wanted to know how to intubate the patient prior to the operation. I have tried to get in touch with the anaesthetist unsuccessfully, but I will succeed sooner or later.
And you have a question in the back? You've been very patient back there.
You're saying about the blueprints of each cavernoma, and how would that work in multiples?
So one of the interesting things, so the question is with multiple cavernomas, what about the bleeding risk? That is a great question. There is one study we're looking at in the US on that, and it's a hard question. I think we've tried to look at both radiographic triggers, are there certain signs like edema around the cavernoma or change in size that might be a sign for bleed. One of the other questions might be in terms of biomarkers, you may be able to say that something is going to bleed, but you might not be able to know which one. And one of my hopes is that we would combine possibly both of those, where you could look at the urine to say, hey, something's up, and then with the radiology findings say, well, this is one of the triggers, and while either one alone might not be good enough to predict, in combination they might be able to provide you with information. But it's certainly a complex problem.
Thank you.